the speaker and the chairpersons. We move to our next session, that is update in the management of heart failure due to systolic dysfunction. To deliver the oration is Dr. Suvro Banerjee, and to chair the session, we have Dr. C. Narasimhan and Dr. Soumitra Rai.
Could I share my screen?
Yeah, you are visible and audible.
So I'll just be sharing my screen.
Please.
Oops, I couldn't. Okay, I hope my screen can be seen here now.
Very well. Very well seen. There is a time. A minute before you get a footer. Go ahead.
Okay, right. So, good afternoon, and thanks for providing me an opportunity to talk on the update on the management of heart failure due to systolic dysfunction. However, I hate to talk on updates, and that is because I am not sure where to start. Should I be starting where I left last time I spoke on the subject? Or should I start from the beginning of this year? Or perhaps from the beginning of the COVID era? Moreover, I do not know how much actually you know, or for the matter want to know. So what I have decided is I'm not going to talk on devices and intervention in heart failure, and rather restrict myself on pharmacological advances in heart failure with reduced ejection fraction. And I will be starting from when there was a paradigm shift in the management of heart failure. And yes, you have guessed it correctly. This is with the paradigm heart failure study, which showed that compared to enalapril, a combination of sacubitril and valsartan significantly reduced cardiovascular death, heart failure hospitalization, cardiovascular mortality, all-cause mortality, and also symptoms. And also the beneficial effect was seen in patients with chronic kidney disease. And it's been seen, like compared to enalapril, only led to a slower rate of decrease in eGFR, and this was also evident in patients with diabetes as well as in those without diabetes. Now, if a patient is on MRA already, then severe hyperkalemia is more likely with enalapril compared to ARNI. Now, a recent publication in ESC Heart Failure shows that ARNI has been effective and safe in patients with end-stage renal disease who are on dialysis. Now, ARNI reduces mortality both due to reducing worsening of heart failure as well as also by reducing sudden cardiac death. Now, a post-hoc study of paradigm heart failure have showed that ARNI reduces significantly 30-day heart failure readmission compared to enalapril. Now, we know that most of the readmissions following a hospital discharge occurs within the first 30 days, and about 60% occurs in the first 15 days. But if you go by the criteria for paradigm heart failure study, then these patients with acute heart failure admitted for the first time probably won't be started on ARNI at discharge. And by doing that, we'll be withholding ARNI at discharge for patients with acute heart failure and deny these patients of potential benefit of ARNI in reducing rehospitalization. So the question is, could ARNI be initiated in such patients after initial hospitalization? However, there are concerns with this approach. There were concerns with this approach. Will patients tolerate pre-discharge initiation of ARNI? Will it lead to more discontinuation? Will it be safe, and will it be effective? Now, two studies actually looked into it, and one of them is a transition study, which looked into initiation of ARNI in hospitalized patients after hemodynamic stabilization. And what it showed that the primary endpoint, which was proportion of patients achieving the target dose, was no significantly different from those who started pre-discharge compared to those who are started post-discharge at 10 weeks. Also, the other study, which is the Pioneer Heart Failure study, showed that in-hospital initiation of ARNI led to greater decrease in NT-proBNP and improved clinical outcomes compared to enalapril. And interestingly, outcomes were similar regardless of whether the patient was ACE or ARBs naive or not. Now, Proof Heart Failure study looked into the mechanism of action of RNA in heart failure with reduced ejection fraction, and showed that it was sustained decrease in NT-proBNP at 12 months, which paralleled improvement in cardiac indices, such that it was seen that patients with largest reduction in NT-proBNP and left ventricular end systolic volume by 6 months had lowest rates of subsequent death or heart failure hospitalization by 12 months. Now let's move on to serendipity. As you know, it means finding something good without looking for it. And nothing could be a more perfect example, like SGLT2 inhibitors, which were initially used in patients with diabetics, but later it was found that they prevent the development of heart failure. So the question is, can these be used to treat patients with established heart failure? And can they be used in patients even without diabetes to treat heart failure? The answer came from the DAPA heart failure study, which included patients with NHA and HYA class 2 to 4 and ejection fraction 40% or less with elevated NT-proBNP, and put them either on dapagliflozin 10 milligram or placebo. And the primary outcome was composite of worsening heart failure or cardiovascular death. And worsening heart failure was defined as either hospitalization due to heart failure or an urgent visit resulting in intravenous therapy for heart failure. And the primary composite outcome was significantly lowered with dapagliflozin compared to placebo, and this was true both for diabetics and non-diabetics. Similarly, the components of the primary outcome, that's the cardiovascular death and worsening heart failure, was significantly lower with dapagliflozin without any difference in the subgroups. Let's come to the secondary endpoints. Now, the cardiovascular death or heart failure hospitalization, total heart failure hospitalization, and cardiovascular death, and all-cause death, all were significantly reduced with dapagliflozin compared to placebo, both in patients with diabetes and without diabetes, and the results you see were similar. And when it comes to improvement of symptoms, dapagliflozin was better than placebo so far as KCCQ score is concerned, and it was again similar in both the subgroups. Now, dapagliflozin caused less worsening of renal function compared to placebo. Again, there was no subgroup difference between diabetes and non-diabetes. And dapagliflozin not only reduced worsening heart failure, but also reduced sudden cardiac death as the cause of death. If you look at the pre-specified subgroups, such as age, sex, race, NYHA class, EF, NT-proBNP levels at baseline, etiology of heart failure, body mass index, baseline EGFR, in all these pre-specified subgroups, dapagliflozin did better than placebo. And the background heart failure therapy did not actually modify the effects of dapagliflozin. As you see, it's not only this is true for devices, but also for drugs. And I have to mention especially about ARNI. So being on ARNI or not did not modify the effects of dapagliflozin in reducing mortality and events from heart failure. Now, if you come to this adverse events, the commonly adverse events that we talk about SGLT2 inhibitors were no different between the two groups, that is dapagliflozin and placebo, and significantly there was no difference between the subgroups as well. And drug discontinuation pursued a similar pattern. Now, perhaps you know that only 2 days ago, the Emperor Reduced trial's preliminary results was out in the press, and that was announced that the results were similar to dapagliflozin. We need to wait for more results for this. Now let's move on to another important thing. What is more important? Is it quality of life or the quantity of life? And again, I would say probably no other study recently exemplifies this as that which arose from the publication of Victoria study, where varicegat was used in patients with heart failure and reduced ejection fraction. Now, you know that in health, nitric oxide stimulates the action of soluble guanylate cyclase, and it leads to increase in cyclic GMP, which has its effect on favorable effects on heart and vasculature. Now, in presence of heart failure due to oxidative stress, there is endothelial dysfunction resulting in less availability of nitric oxide. Now, varicegat is an oral soluble guanylate cyclase stimulator. And what it does, it not only stimulates the guanylate cyclase activity, but also it sensitizes the guanylate cyclase to the endogenous nitric oxide. And this is the way it has the beneficial effect in heart failure. In the study, patients with chronic heart failure were class NHYA class 2 to 4 symptomatic and ejection fraction less than 45% were considered if they had a recent worsening heart failure event. And Variciguat was titrated up to 10 milligrams a day and compared with placebo, and it showed the primary composite endpoint, which is the cardiovascular death or heart failure hospitalization, was significantly reduced with Variciguat compared to placebo. But this was driven mainly by a reduction of first heart failure hospitalization. And there are other secondary endpoints. But I would like to say that the drug was quite safe and tolerable. There was higher incidence of symptomatic hypertension and syncope in patients on Variciguat, but this was not statistically significant. Also, more anemia developed with Variciguat compared to placebo, but there was no adverse effect on renal function. So Variciguat was significantly more effective than placebo in reducing the composite endpoint and also heart failure hospitalization without any significant change in all-cause mortality. It was safe and well tolerated. And NNT for 1 year to prevent one primary outcome was 24 patients. Now let's see what's there in the pipeline. Now, as we know that in heart failure with the reduced ejection fraction, the crux of the matter is reduced contractility. And if we can have something to increase contractility, then it's likely to produce good results. Now, we have conventional inotropic agents, which have been shown in short time to improve contractility, but with long-term use have detrimental effects on myocardial energetics, resulting in negative clinical outcomes. But apart from these usual inotropes that we use, and we call them calcitropes because they involve with increasing intracellular calcium concentration, we also have myotropes and mitotropes. Now, one example of myotrope is omecamtiv mecarbil. And what it does, it is a selective cardiac myosin activator, and it binds to myosin, stabilizes myosin in pre-primed position, and by that, it increases the number of myosin heads available for contraction, thereby generates more force for each contraction. It is analogous to using quite a few hands in pulling a rope compared to using a single hand. It increases the duration of systole, increases stroke volume, but does not increase myocardial oxygen demand. And in a phase 2 study, which is the Cosmic Heart Failure Study, it has been shown to have favorable effects on heart rate, NT-proBNP, and left ventricular indices. Now, the Galactic Heart Failure Study is on its way. It's a phase 3 study used in where the drug is used in patients with symptomatic heart failure and ejection fraction 35% or less, and the primary endpoint is cardiovascular death or heart failure event, and we are waiting for the results to come. So what is an update? As Cambridge Dictionary defines it, it is to make something more modern or suitable for use by adding new information or changing its design. And hopefully I've been able to do that successfully. Thank you very much. I think I have finished within the stipulated time. And I'm going to stop sharing the screen now. Thank you.
There is a question about a very nice talk and summarized very well. Dr. Arupdas Biswas has asked how many drugs at what sequence, I don't know what, pulse, blood pressure, sodium, potassium, because the pill count increases for a person with heart failure. Unless there's a great benefit, we shouldn't be going on adding drugs. So what will be the sequence? Probably that's the question.
Okay. Yeah, I think now we have foundational therapy for heart failure. And if I can just put it this way, we have now 4 medications with 3 pills. That is, we have beta blocker, we have MRA, and we have ARNI, which is actually a combination of 2 pills, which we can substitute for ASOAPs. We already have this. And on top of that, probably we have a DCGI approval now for your starting SGLT2 inhibitors. Now, the question is, what should be the sequence? Now, I think although the ESC guidelines have given a sequence, saying like the first should be beta blocker and ACE inhibitors, optimize the dose if the patient is still symptomatic, add MRA, and then still symptomatic, go for ARNI. But the ACC really doesn't go for this hierarchy. And they go for individual, the sequence should depend on the individual patient. So I think the same we should do. For example, if the patient has heart failure, it's not being, and the may or may not be symptomatic, but should we deprive this patient who is already on, say, ACE inhibitor or ARNI, beta blockers, and MRA, should we be depriving them of the added benefit of SGLT2 receptor inhibitor? Now, I think probably we shouldn't. Of course, there are reasons the pill count increases, which may decrease the compliance. There may be financial implications as well. But if we just talk technically from a scientific point of view, we should be using all these medications. However, for individual patients, we may have to modify depending on the situations. That would be my take.
May have time for one more question.
May I have a comment, sir?
I just, Shomitra, just once again, I want to have Dr. Narasimhan's comments on this number of drugs. What Dr. Dasbiswas has asked, then you, Shomitra, come in for your comment.
Okay. So I have a slightly different take on this. The definition of diabetes is arbitrary. We take a magic number of 110 or HbA1c and call it as diabetes, no diabetes. If you look at it, a lot of heart failure patients have insulin resistance, but with a normal blood sugar, normal HbA1c. So if you do a HOMA-IR in these patients, you will be able to find that they have significant insulin resistance. Short of HOMA-IR, the other surrogates are if a person has something like high triglyceride, low HDL, high uric acid. These are all surrogates for metabolic syndrome. So if you look at the study, even the DAPA-HF, the difference in survival in the diabetic group was much higher compared to the non-diabetic group. So my role would be to kind of assess a patient and see if this patient has insulin resistance. If he has insulin resistance, almost 50% of heart failure patients will have insulin resistance. Then I may introduce DAPA, provided there is no concomitant risk for lactic acidosis, so on and so forth. I fully agree, foundational therapy in terms of reduction of sudden cardiac death, beta blockers, and ARNI should suffice. If a person has done very well and remodeled very well with a combination of good dose of mineralocorticoid, MRAs and others, probably will also be cognizant to keep the pill count to as little as possible because he's going to be on statins, antiplatelets, so on and so forth. That will be my take on this.
Dr. Rai, please.
I have a comment. Knowing Dr. Shantanu Guha more closely than most people, I take him on face value. So if you see the face of the subject, it is the heart failure with systolic dysfunction, not heart failure with reduced ejection fraction. So why he went out of his way from the convention? So this systolic dysfunction is a very, very versatile term. And if you go back to the history of the heart failure trials, from beta blocker to ACE inhibitor to MRA, you will see that ejection fraction cutoff was widely varied as an inclusion criteria, starting from 35, 40, 45, even up to 50% ejection was taken in most systolic heart failure trials, many trials. So if you go by the 2 editorial and 2 papers published this last week's European Heart Journal, by as much as by people like Milton Packer and McMurray, you will see that they are trying to abolish the concept of a pig. They are saying either it is a malnourished elephant or an overfed mouse. There is no such element as a pig. So that's why I think that mid-range ejection fraction is trying to be abolished in near future. It is either an improving heart failure with reduced ejection fraction or a deteriorating heart failure with preserved ejection fraction. And it will come in all discussion of heart failure with systolic dysfunction. To this present knowledge, there is a good attempt that ARNI may be effective up to 57% of ejection fraction and downward. And we are very hopeful of the newer trials of SGLT2 inhibitor, which will take care of this group along with the above 50% group. So I think this 40 to 50% group also comes in today's discussion, and the same number of medicines and same philosophy should be followed without getting flustered around what to do with this group. That is my take on this subject.
There's perhaps Suvro can answer one question. There are quite a few, but we won't have time. Position of ivabradine in heart failure.
Yeah, I think, as we know that EAC has given it a class 2A indication in patients with ejection fraction 35% or less and in sinus rhythm. And I think that's, and if the heart rate is, of course, above 75. So I think there I would go for ivabradine. Otherwise, probably I wouldn't.
There are lots more questions, but perhaps the time won't allow us. So, Dr. Narasimhan, please wind up the session.
Thank you very much. I think there are a lot of uncertainties, and we are learning more about a combination of drugs. And that was a very good summary about the update on heart failure with reduced ejection fraction. And as the discussion brought up, there are a lot of uncertainties, and it's still an evolving field, and we'll have further knowledge by the end of next year. Thank you.
Thank you very much, the speaker and the chairpersons.